Okay, I think we'll make a start. So good afternoon, everybody, and welcome to our session for carers of people with dementia, about carers of people with dementia. Now, this is a point I would normally do the housekeeping, where, you know, I would show you the exits and where the toilets are, but I'm sure you're all very aware of where your own toilets are and where the, in an emergency, how you would exit from your home or wherever you are at the moment. So I think I can skip that bit. Now, I'm particularly delighted to be here chairing this session. And first of all, I'd like to say how astounded I am at how the Alzheimer team have come together. They've continued to pivot during these past 7-8 months, and they've pulled this conference together in this virtual format, which I think is completely astonishing. And I'd just like to congratulate the whole team, because it's certainly pushing my boundaries and comfort zone. So who am I? Well, my name is Jayne Goodrick and I live in beautiful North Wales. We have the seaside on one side and Snowdonia on the other. Both my husband, Chris Roberts, who some of you may know, and my mother have diagnoses of dementia. And as the saying goes, when you've met one person with dementia, you've only met one person with dementia. My mum's dementia presents totally different to how Chris's dementia does. So this is a topic that's very, very close to my heart. Carers of people with dementia. And I am thrilled that each of our speakers today, each of their presentation will be speaking to me personally. They'll be presenting their research in areas that I personally find very, very relevant. And so would everybody caring for somebody with dementia. So to begin, I'd like to introduce our first speaker. Our first speaker is Kirsten PEETOOM, and she works as a postdoc researcher at the Alzheimer Centre, Limburg, the Netherlands. Now, her research projects primarily and very strongly focus on young onset dementia. As I've just alluded to, my husband was diagnosed with dementia at 50, so this is really, really relevant for me. And she coordinates, among other projects, the development of the Dutch version of the RHAPSODY programme. Now, this has been pre-recorded, so hopefully our techie guys will now show her recording of the research. Over to Kirsten's recording, please.
It will take about 1 minute more. We are still letting people in and it's downloading at the moment.
Okay, that's fine. It's quite interesting the way this platform's working, because we've all been forced into using the Zoom platforms, the Microsoft Teams platforms. And I really think it's going to be moving forward into the future. I don't think it's going to take the place of a live conference, because nothing can beat that networking where we all get together. But I think it is going to open the conferences up for those people that may not be able to travel due to time constraints or work commitments. So I think it's really something, well, it is completely innovative, that maybe in the future we'll have, do they call it a double platform, where it's live and streamed online. So I think now something's happening on my screen. Don't know if Nick, the moderator, can help us there. If you've got any questions for any of our speakers, please do put them in the chat box. It would have been on a different platform and I would have had to have gone into a different room to actually read them. But because of some technical difficulties, it's actually made it much easier for me, because all your questions can go into the chat box. Our speakers can choose the questions they want if it's directed to them, or maybe we'll pull some out if there are a few the same. And this is where you feel like the newscaster where the presentation hasn't appeared. If anybody has any questions, please do put them in. There's some nice comments coming through, and I'm very happy to see everybody here. It's good to actually be doing something a little bit more wider than our local area. As I've said before, I live in Wales, UK, and we're a nation of 3.5 million. So we feel...
Deze erin blijft zitten.
Zeg je?
Want ik heb hem nu hier en dan kan ik hem gewoon openen.
Ja, doe maar gewoon.
Ja?
Kan. Ja.
Okay, we can start.
Okay, once again, I'd like to introduce Kirsten. Kirsten's PEETOOM works as a postdoc researcher at the Alzheimer Centre, Limburg, and she primarily focuses on young onset dementia. She's coordinating among the other projects the development of the Dutch version of the RHAPSODY programme, which we may get to hear a little bit more about. Over to the presentation.
Hello, my name is Kirsten PEETOOM, and in my presentation I will focus on RHAPSODY, a web-based multimedia information and skill-building program for carers of people with young-onset dementia in the Netherlands. Young-onset dementia means that the first onset of symptoms occurs before the age of 65 years old. It has an enormous impact on the person itself, but also on its carers, as they are in the active life phase. And often financial problems may occur due to symptoms of the disease, such as inhibition, but also due to job loss. Carers experience a high level of stress, burden, and sometimes also depression. We also know that adequate support is lacking, and it mainly focuses on supporting carers of late onset dementia. RHAPSODY is a European project involving institutions of Sweden, the Netherlands, Germany, the UK, France, and Portugal. The aim of this European project was to develop and test a web-based information and skill-building program for carers of people with young onset dementia. To do this, they first conducted surveys to obtain insight in the policy and information environment, and also a survey of needs and access to care. Based on these surveys, they designed an e-learning program for carers of young onset dementia, because the survey showed there was a lack of adequate support and also a lack of information. The program focuses especially on information and also on skill building. The e-learning was tested in a pilot study. The program was available for 6 weeks, and 61 carers of the UK, Germany, and France made use of it. The pilot showed positive results. The participants found it was very easy to use, easy to understand, that the information was very relevant, and also they were intended to use it in the near future. They would also recommend it to other informal caregivers. And now, because the program is available already for France, the UK, Germany, and Portugal, and based on the positive pilot results, we're now going to develop a Dutch version of the program. These are the parties involved in creating the Dutch version. And also you see here the people who are involved in our project group to create this version. This is a stepwise approach to create this Dutch program. So we had to build the Dutch version, but we did this based on the previous developed RHAPSODY web-based program of the other countries. This meant that we had to translate and adapt the text and videos to the Dutch situation. Also, we implemented the Dutch version on dementie.nl, and we developed a communication strategy together with stakeholders. At the moment, we're in the middle of our pilot evaluation, and we're evaluating the usability, accessibility, user experiences, and web metrics. The pilot evaluation aims to gain input from informal caregivers, but also from healthcare professionals. This is a quick overview of our program. In the top left, you see the 6 chapters. Chapter 1 is focused on the medical background of young onset dementia, where chapter 2 focuses on the problems and solutions, 3 on behavioral changes, chapter 4 focuses more on the impact on the family, chapter 5 is how to care for yourself, and in chapter 6, the available care and support in the Netherlands is the focus. The program also includes videos. In this video, Professor Marjolein de Vught, our Dutch expert, reflects on the story of Xulia. Xulia just told her experience with caring for her father with Alzheimer disease. We also included animations and also questions to reflect on your own situations and the content they just read. So here we have an overview of the main topics of the chapters, but we also have subtopics within the chapters. This is from chapter 6, and you can see there's also a focus on support for the people with young onset dementia, and there's a focus on the support for the informal caregiver. Now I'm going to give you a quick tour through the program. So we first start at the website of the Alzheimer Europe conference. We are here in the agenda. And we go to the website dementie.nl. Here we go to help and advice, and go to the training Young Onset Dementia. This is the main page. On the first page, there's more background information about the project, about the program, how to use it, and also we introduce our experts. These are Professor Marjolein de Vught and Dr. Christian Bakker. Here we also provide information with some background information about every chapter. And below you can navigate to the different chapters. It is not necessary to start with the first chapter. You can start with a chapter you're interested in at that time. Also below, the visitor can read more about the RHAPSODY project and see which partners are involved in creating this training. Now let's zoom in to Chapter 1. Chapter 1 is focused on the medical background of dementia on a young age. We have several subtopics. So what happens in the brain, the diagnosis, heredity, and also what kind of forms of young onset dementia exist, and also treatment. We're now going to zoom in the different forms of young onset dementia. So here we focus on Alzheimer's disease, frontotemporal dementia, and they can also read more about Lewy body and vascular dementia. We go more into depth about Alzheimer's disease and frontotemporal dementia, but they can click on the link for more information about Lewy body and vascular dementia. So if you go to Alzheimer's disease, there's like a subchapter. First, there's the introduction movie of Professor Marjolein de Vught about the medical background of Alzheimer's disease, what you can expect, and also the symptoms. Every video includes a short summary. So you can click here and then you can read the main points of the video. Next to videos, we have textual background where they can read in their own pace. We also have graphics to support the information. Here they can read more about the problems they can experience with cognition, behavioral changes, or problems in executing daily tasks. Here is the story of Sudia. As I mentioned before, she's a former caregiver of our father who was diagnosed with Alzheimer's disease when he was just below 60 years old. And Marjolein de Vught, our professor, she's reflecting on her story. Also, this page includes information about risk factors, atypical forms of Alzheimer's disease, and they can click here for more information. Now we go back to the beginning of Chapter 1. So here you have the 6 chapters. Now we're going to zoom in a little bit more on the Chapter 6 about the available healthcare and support in the Netherlands. First is again an introduction movie. This is for Christian Bakker. And here are the different subtopics. So we have information available for the person with young onset dementia, but also information for caregivers. We have more information about the law, what to arrange, and also about institutionalization and what you have to arrange and expect. Within the page for informal caregivers, we have more information about the available support in the Netherlands. Here they can see what is available by Alzheimer Netherlands, but also how to arrange a case manager, how to find peer support. And we have also here a link to FTD lotgenoten and to interventions like partner imbalance. Here's also a section where they can find more information. So we're now in the midst of our pilot. Visitors will receive a pop-up. And this will, if they agree to participate, they will receive 2 surveys which will help us to improve this training. This was my presentation. Thank you for listening, and are there any questions?
Right, thank you for that, Kirsten. That was really interesting. I've come up with something that I'm going to jump in and take the first question. There's a question come up that was going to be mine. The question is, I know it's pre-recorded, but is this Dutch information only available for young onset dementia? Is it only, my question would be, is it only available in Dutch, or is there any way we can access it in English?
Yeah, so this presentation was about the Dutch version we just recently developed. But the program is also available in the UK. There's also a version in Germany, in Portugal, and in France, and also one coming up in Sweden. So yeah, it is available in different languages, but we also the program's not the same in every country. So we have our own additions. So for example, the chapter on available care and support, that's for every country, is that different.
Thank you. What I'm going to ask you to do while the next speaker is speaking, if you can have a look through any of the questions and perhaps note a response, and then at the end we'll give you time to address the questions then as well. Yes. Thank you very much. Very interesting. Now I'd like to introduce you all to Tamara BACKHOUSE. Now she's a postdoctorate research fellow based at the University of East Anglia in Norwich here in the UK. Now, with over 20 years experience working in care homes as a care assistant, she completed her PhD in 2014, and her research interests focused on dementia care, particularly the practical aspects of coping with situations that caregivers experience as difficult, both in the care home, in home care, in hospital, and also in family settings. Well, while we're waiting for the presentation to come up, I'm going to perhaps ask some of the questions from the chat box for Kirsten. Now, you mentioned that the RHAPSODY programme had positive results, but can you please elaborate a bit more about the impact of the programme on carers of people with young onset dementia?
Yeah, so the positive effects were arising from the pilot study that was conducted in 3 countries. So it was in the UK, in Germany, and in France. And there were indeed positive results. So they looked into the stress, also burden of informal caregivers, and they compared 2 groups. So one group was on the waiting list, and the other group used the program for 6 weeks. What, for instance, they saw is that the group that used the program had lower levels of stress and also from burden. And also that they had the feeling that their self-efficacy to cope with the behavior problems, that was also more positive in the group that used the program. So it helped to...
Hello, my name's Tamara.
Yeah, so...
That's great to hear. You know, the results speak for themselves there, don't they? Okay, we'll go to Tamara's presentation now, please.
Hello, my name's Tamara BACKHOUSE. I'm a research fellow at the University of East Anglia in the UK, and I'm going to talk today about strategies to manage refusals of care in dementia and examine both care home and family carer settings. So first, we'll look a little bit about what refusals of personal care are in dementia, and then at the methods we used in the ProCare study. And then at the key themes from the data and some of the examples of the data. And then we'll look at a comparison between family carer settings and care home staff settings. So assistance with personal care is any assistance or support given to the person in connection with their eating, dressing, bathing, going to the toilet, oral hygiene, nail and skin care. And sometimes in dementia, the person may refuse assistance with these activities. So they may just verbally refuse by saying no. They may stiffen their body or push things away, or they could be physically or verbally aggressive, grip onto things, hug things, look away or lean away from the person. They may become visibly upset, clamp their jaw, or just ignore offers of assistance, or not physically cooperate by making themselves heavy, for instance. And there's many reasons that a person with dementia may do this. And one is that they don't understand the caregiver's intentions. And we can all identify with that. If somebody came to help us undress and we didn't know what they were doing, I think we may all refuse their assistance. Other factors could be environmental factors, like it may be too cold or noisy in the room. The health status, there may be an underlying infection. They may have delirium, depression or delusions, or even be in pain or have other unmet needs such as hunger or thirst. They could be embarrassed, or it could be the caregiver approach, maybe abrupt or a patronising approach, which may make the person not want to receive the assistance. Refusals are most common in the severe stages of dementia, and they can occur in family, hospital and care home settings. And they're distinct in that they always occur within an interaction, within a personal care interaction. And there can be consequences of refusals. The person doesn't get the care they need, they may become sore, or they may lead to crisis points when it becomes too difficult between the caregiver and the person themselves. So the ProCare study is looking at refusals of personal care in dementia in lots of ways, but the aim of this study was to identify the strategies used for managing refusals in family and care home settings. And we use qualitative face-to-face semi-structured interviews to do this. And we've used a qualitative content analysis approach, an inductive approach, with the aid of NVivo to help us manage the process for the analysis. And so far we have 20 family carers of people living with dementia in their own homes and 12 care home staff. And these are staff, care assistants on the front line, actually helping people with the personal care, not managers or seniors. So the key themes coming from the data are acting to prevent refusals occurring, communication strategies, leaving care uncompleted or adapting care, and support and safety. So acting to prevent refusals occurring, both settings, the key strategy here was leaving the person and going back. If they felt a refusal may occur, they would leave the setting and then return later. So this care home staff member is saying, if a person is very distressed and then sometimes it is better to walk out of the room and leave them and go back 5 minutes later, because especially somebody with dementia, they won't even remember you coming in the first time. And you might find they're in a lot better frame of mind the second time you go in. And then, like I say, this was a key strategy in both settings. Family carers also would assess the person's mood before starting care and perhaps not start care if they felt a refusal might happen. They would pick their battles. Well, is it worth making the person upset? Do they really need a shower today? And they would also make sure they had time. Time was a real pressure for family carers, especially if they had an appointment or the person went out to a daycare centre. Some family carers would find themselves getting up very early so they had enough time to get through all the care activities so they wouldn't be late, or they would do less care that day so they were less stressed. In the care home settings, care home staff would look for unmet needs. If they thought a refusal might happen, they may try to work out why that could be beforehand. They would distract the person, make sure the person was calm before trying any care activities. And they found that knowing the person was key here to help them know how to distract the person and also help them follow the person's routine to have them more likely to come along with the care activity. And they also adapted their approach, saying that a cheerful approach was more successful to reduce refusals. Communication strategies. The key strategies here again were used across both settings. So encouragement and explanations. So encouragement. So this family carer saying, like coaxing, yeah, mum, you need to drink. Come on, you need to drink. You know, the doctor said you should drink, trying to convince her that it's good for her. And in terms of explanations, the care home staff member here is saying, like showing, you know, you've got no knickers on, we need to put these on, or they are wet, we need to get a new one, just by explaining, by showing them to make them understand a little bit. So encouraging and explaining were key strategies to try and get the person to accept assistance with their care. So family carers also would show emotion. Sometimes they may become upset or angry with the person to try to get the person to receive the assistance. And they would tell the person, you've got to, and be quite firm with the person. Sometimes that was their approach. And some would threaten them with consequences. For instance, we can't go out today unless you're dressed properly, or I'm not living with you if you don't have a shower, things like that. And care home staff would simplify the sound of the task, or we'll just go and do this, or we'll quickly do this, or it won't take a moment. So they would minimize the sound of the task in the hope the person would accept the help more readily. They also said they used humour a lot, and occasionally they would tell off the person, especially if they were aggressive, to make them realise that their behaviour was not acceptable. There was an acknowledgement here that the person may feel guilt because of their behaviour, but in certain times when the person was aggressive, they felt that this strategy worked. Leaving care undone or adapting care, so both settings would do this. They would leave care uncompleted. So a family carer here is saying, everything really is a potential battle. So anything I can do or overlook or not bother with is a bonus. He wouldn't get dressed at all, particularly sort of winter time. And then offering reduced care. So, I mean, there were occasions when staff wouldn't shave him, couldn't. I think it happened more and more as he progressed his dementia. So the family said, just leave him. If he grows a beard, it's better than upsetting him. So instead of the shaving activity, they just cared for the beard in the end. And then offering a different mode of care. I wouldn't push her to the point to say, you've got to have a shower. I don't think it's fair on her, and I don't think it's necessary, because I can give her a good wash and probably check her better as well without me getting soaked as a care home staff member. So this was a key strategy as well, offering a strip wash rather than a shower or a bath, or sometimes less frequent hair washes, or using dry shampoo instead of usual shampoo. Family carers would also try different times of day, and care home staff would try to take more time. And these were also strategies to reduce refusals and to manage the refusals. Support and safety, there were no unified approaches across the settings. Family carers relied very much on neighbours and family members, and the health services and emergency services. One family carer had rang the emergency services after an aggressive incident, and she says here, if he was successful in realising that I was afraid, it would become very, very difficult. So I think it was the best way to go. And this was the way that the family carer had got into the support system, the crisis intervention team. And care home staff relied heavily on the staff team for their support, physical and emotional support, and support for ideas of how to best approach the person and look after them. They often had double ups with two people going to the person in the moment in the care interaction, and they would consult with the person's family, but more to check the family were happy with their existing approach. So a care home staff member here says, when there's two of us, we tend to sort of have a bit of banter with him, one to actually try and distract him a little bit. And if there's two of you, one can actually talk to him face to face and the other one assists him. So here's our comparison, and we can see there's some unified themes across the settings in the purple. And we can also see that family carers was slightly more cautious, assessing the person's mood before starting care and picking their battles, but also showing more emotions, whereas care home staff would look for unmet needs, try to know the person and adapt their approach. So in conclusion, both settings use the same key strategies in prevention of refusals, leaving and going back, the communication strategies, explanations and encouragement, and adapting and reducing care if needed. Family carers were more cautious and emotion-led and had limited immediate support for them. They had more of an internal view on the situation. They were in it and a bit more reactive, where care home staff had a more considered approach with team support. Things may be discussed and they'd go in with a game plan, a bit more of an external planned view on the situation. And approaches to managing refusals reflected the relationship and the closeness the caregivers had with the person, either professional or personal. Although professional relationships could be very close, and sometimes the personal relationships were not as close, but the relationships really were key in the way that the refusals were managed or tried to be reduced. Thank you very much for listening.
Okay, thank you, Tamara. That was very interesting. And the thing that jumped out for me was that I fully endorse the pick your battles. That is so true. But the coaching for me, it's I don't coach him. It's here's a drink, drink it. But that's what works for us. Now, it does sound like the carers are finding it quite hard to manage the refusals of care. So flexibility seems to be quite the key there. And perhaps more support would be useful for family carers. I think we've seen earlier with the training that really helps. It gives people confidence and resilience to carry on. Do you have any idea which strategy or approach was the most successful?
Thank you. We weren't looking at the success of the strategies, but it came very much to the front that care home staff were much more likely to use the leave and go back strategy, whereas family carers would offer more reduced care and less care, or perhaps leave the care for another day. So I'm not sure how successful they were, but family carers, decided to withdraw a little bit, and so did care home staff, but in a different way. Care home staff would go back to complete, whereas family carers may just adapt or reduce the care that was provided.
Yeah, I think that shows the importance that professionals have their place. A lot of people are concerned about care settings, but they're the professionals, they know what they're doing. So thank you. I'm sure there will be more questions coming in if you could have a look and perhaps formulate some answers for later.
Okay, thank you.
I'd now like to introduce Nina ZERRAR. She's worked for 4 years at Fundation Mederic Alzheimer after completing a PhD in economics on risk perception and long-term planification, LTC planification. I did have to Google that, but it's long-term care planning. And one of her focus of interest is the perception bias. She also whilst working, she also continues studying long-term perceptions, more precisely Alzheimer's perceptions, and she started work on informal care and its consequences on carers' well-being. So I'm fascinated to find out what the findings of the research are. If we can go over to you, Nina.
Thank you, Jayne. Good afternoon, everyone, and thank you for attending this session. So I'm Nina ZERRAR. And today I'm really happy to present you our new results on portrait of carer and dementia perception in France. So for today's presentation, I will have a really classical outline. I will begin by presenting the data I used to make that study. And then I will focus on two main topics in our result. The first one is dementia perception. And today we will try to have intention on something that we can call dementia care literacy. And then I will finish by presenting a portrait of carers in France, in particular people with dementia carers, from their socioeconomic characteristic to the consequences of their intensive care on their well-being. So first, for this result, I use ELDER's Wave 4 data. So ELDER stands for Survey on Longevity, Dependency, Risk and Support in French. It's a quantitative mailing survey that we run every 3 years at Fundation Mederic Alzheimer on two main topics: informal care and long-term care anticipation. So about the Wave 4 I used today, the data collection was run between March and May 2020. So we had to make a second mailing due to the COVID-19 context. It led to our third barometer supported by Malakoff Humanis. And for this analysis, our targeted population is the French population aged between 40 and 79. So people most likely to be carers or in time to anticipate their long-term care and their future. So for this new wave, we introduced a specific question on Alzheimer's, and thanks to work with Cantar Public, we managed to have a sample of more than 6,500 respondents. So these respondents are representative of the French population. That means that they are not necessarily exposed to long-term care or dementia in their daily lives. So there is one methodological hypothesis I want to share with you in Elders 2 is how we define a caregiver. So we do that thanks to two questions. The first one, we ask to respondent to declare what they do for their parents and their parents-in-law. So help for activities in daily living or instrumental activities of daily living. And we also add items on overseeing, financial and material transfers, and online administrative tasks. Then we ask at what frequency they do this task. And at the end, we are able to categorize a respondent as a caregiver if she or he provides help to at least one parent or parent-in-law for at least one of the listed tasks and at least once per month. This definition leads us to identify more than 1,600 carers in our sample. And then we ask the respondent also to declare their parents' limitation. And between these limitations, we know if the parents have trouble with memory, orientation, or concentration. This helps us to identify between all our carers more than 500 individuals that help an elderly with a cognitive limitation. So with this definition, we can map our sample as follows. And as a first result, we can say that 1 out of 4 French citizens aged between 40 and 79 years old provide care to at least one parent. And in 1 out of 3 cases, this parent has a limited cognitive limitation. So now I will begin by presenting the result on the whole population, and we will focus on dementia perception in France. So what we wanted to do is to somehow measure dementia exposure in the French population. First, in the private life, so we can measure with thanks to that survey that 44% of the respondents have at least one relative diagnosed with Alzheimer's, but also we wanted to measure somehow some kind of public exposure, so in the public information. So we know, thanks to that studies, we know that French population thinks at 54% that they are enough aware of Alzheimer's disease, and they hear often or very often about Alzheimer's in the last 6 months. And the informational resource, we know that these results depend on whether individuals are exposed actually in their private life. It's a relative for people that are exposed in the private life, and it's through documentaries in the media or the radio for 55% of people that are not exposed in their private life. So even if the information they have is different, what is interesting is that French people share their dementia perception even whereas they are exposed or not in their private life, because they use the same word to describe Alzheimer, and they use also the same word to describe their feeling regarding Alzheimer. And another interesting fact is that dementia is now a real concern when French people think about their future. They are 28% to think that they are strongly likely to develop Alzheimer at age 80. And also they think that 62% declare that their environment is not adapted to cognitive limitations. So we wanted to understand that strong probability to develop Alzheimer at age 80. And to do so, we propose something that we can call Dementia Care Literacy Score, that is based on questions along 4 dimensions of care: diagnostic, state benefits, housing, and carers' rights. So thanks to this question, we are able to compute one global score of dementia literacy score, care literacy, that will sum +1 for good answer and -1 for incorrect answer. We can also build 2 derived score, one that counts good answers and one that counts wrong answers. We are now allowed to use these variables. These scores are as explanatory variables of the self-reported probability of having Alzheimer at age 80. And our results, regression results, show that only wrong answer impact this probability. So in other words, when individuals anticipate their future, they base their beliefs on misinformation. This result suggests that we really need to improve that dementia literacy. I will now focus on the subsample of carers, and we'll begin by look at the characteristic and the differences between people with dementia carers from other carers. And we found finally only few differences between this kind of carers, but these differences are not minor. People with dementia carers are more often females and unemployed, but the last one is related with the fact that they are older. And when we look at the care they provide, this care is also different, because if we look at with this facing the same needs, we can say that because they have the same care duration, they help the same number of parents, but carers to elderly with cognitive limitation provide a more intense help in terms of frequency, number of tasks, and financial help. In particular, for time-consuming tasks, hardly compatible with a job or social life. So now this is said, we want to know to what extent this intense care impact carers' well-being. So we look at well-being, 3 dimensions of well-being: work life, health, and social life. And we found no evidence of an impact of care on work life and social life and care of carers. But our results shows some evidence of impacts of intense care on self-reported health, on PHQ-8 mental health score, and also on anxiolytic consumption. So if there were 2 key messages I want you to take away from this presentation, the first one will be that dementia perception are socially shared, whether or not individuals are exposed in their private life. But dementia care still needs to be, literacy still needs to be improved. Also, I think that this study brings forth new evidences that people with dementia carers provide a more intense care and thus might be more exposed to care consequences. And if I can finish, I will say, so sorry for non-French readers, because French readers, if you want, you can download our third barometer on our website. Thank you for your attention.
Thank you, Nina. That was, again, they're all very, very interesting, and they're all very, the research is very close to my heart because I am impacted personally with those. I was really, I took a note that when you said the wrong answer impacted the probability of their thoughts, that does seem to be a human condition or one of our failings throughout all aspects of our life, that we can, our fear of something may not be based on actual fact. So I found that very, very interesting. Now, correct me if I'm wrong, but there didn't seem to be much difference between carers of people with dementia versus carers of people with no cognitive decline in the amount of work they do. Was there anything looked at into when somebody might go into residential long-term care settings? Did that impact?
No, we find no evidence on the place where the elder is living. Yeah. I don't, yeah.
Okay, thank you. Again, if you've any questions for Nina, pop them in the chat. She'll have a look and we'll address them all at the end. Now, I'm hoping that the techie guys have had time to organise the next recorded presentation. This one is from Anya from Ireland. Anya is a final year PhD student in the National University of Ireland, Galway. Her research broadly focuses on the psychosocial supports for family carers of people with dementia. And today, she'll be presenting her findings comparing the carer burden between family carers of older people with and without dementia in Ireland. So if the presentation is ready.
Hello everyone, my name is Anya Tehan. I'm a PhD student in the Centre for Economic and Social Research on Dementia based in the National University of Ireland, Galway. My PhD focuses on family carers of people with dementia, and today I will be presenting a secondary analysis of a national data set comparing care burden levels of family carers of people with and without dementia in Ireland. So Ireland, similar to other Western European countries, is experiencing an ageing demographic. Given that age is a risk factor for developing dementia, it's projected that the prevalence of dementia will increase significantly here in the next few years. So for us in Ireland, the provision of long-term care to the increasing number of people with dementia is a major policy focus at the moment. To date, there have been two avenues for long-term care in Ireland, so nursing homes or community-based care. So cost and the preferences of people with dementia have resulted in policy movements away from nursing home care towards community-based care. However, despite these moves, the majority of community-based care to older people and to people with dementia in Ireland is provided by family carers. So in Ireland, family carers have very much been regarded as a free resource within long-term care planning for dependent older people and people with dementia. So from the perspective of family carers, the care they provide comes at a very high cost. So international studies have highlighted that care burden is associated with care burnout, decreased physical health, quality of life, and increased levels of depression. And this evidence alone suggests that addressing care burden is a population health concern for current and future family carers. Second, aging in place policies which redistribute care from nursing homes back into families we consider alongside policy changes which have indirectly reduced the availability of informal care, including kind of increased female participation in the workforce and increasing retirement ages, mean that aging in place policies might not actually be sustainable, as family carers are basically the foundation of community-based care in Ireland. And then given that family carers are so essential in the delivery of long-term care to people with dementia and older people. Understanding and reducing the experience of care burden is a really important policy issue. So building on these motivations, the aim of this research was to compare care burden among family carers of people with and without dementia in Ireland. The first step was identifying determinants of care burden for family carers of older people and people with dementia in the literature, followed by a secondary analysis of a pre-existing national data set. So we identified a national cross-sectional data set which collected data on family carers of older people in Ireland. This study was carried out in 2013 by researchers in the University College Dublin, who we collaborated with on the study. This was an anonymous postal survey and was facilitated through the Department of Social Protection in Ireland, giving access to family carers in receipt of carers allowance. So although the survey didn't ask what specific condition people had, a survey item asking if the older person had dementia was included. So the survey included questions related to socio-demographics of the family carer and of the older person, caring activities, carers' health, well-being, coping and support available to them. From the offset of the study design, our dependent variable was care burden. In the survey, care burden was an ordered categorical variable with 4 levels. So low, mild, moderate and high, and it was measured using the 22-item ZERRAR burden interview scale. So reviewing the literature, we identified variables which have been associated with care burden in family carers of older people and people with dementia, and these included the socio-demographic variables on the older person, family care, and also variables related to the context of care. Then the next few slides will give an overview of independent variables and a breakdown of sample percentages. So independent variables which have been found to be related to care burden in family carers of older people and people with dementia included dementia, so whether someone had a diagnosis, the age of the older person, gender and dependency levels were identified as relevant variables to include. One area which was very important for us as a research team to reflect on was that while we had a lot of experience doing research on family carers of people with dementia, this study was looking at 2 groups. So we had to identify determinants of care burden in the wider population of older people as well as people with dementia. So identifying important variables was guided by literature on family carers of older people as well as with research specifically focused on people with dementia. Similarly, when identifying family care variables of interest, both dementia-specific and more general older person research informed our decision, and family care variables included age, gender, marital status, education status. Then finally, the variables related to the context of care included relationships with the person being cared for, residence, so where the family carer lived, hours spent caring per week, duration of caring measured in months, co-residence, so whether the family carer and older person lived together, and the perceived quality of support received by the family carer. And you might also have noticed that we've included rows outlining the percentage of missing data for each variable, and once we had accounted for the missing data, our final sample was 1,992. Moving on to our analysis, the dependent variable in our analysis, care burden, is an ordered categorical variable. Consequently, we estimated a multivariable ordered logit model to assess the independent relationship between care burden and dementia status of the older person. Using this approach allowed us to assess whether or not family carers of older people with dementia were more or less likely to experience higher or lower levels of care burden than family carers of older people without dementia. And then finally, prior to our final model, we conducted sensitivity and robustness checks where we estimated models with different subsets of control variables, starting out with a univariate model including only dementia, and then followed by incrementally adding in control variables related to the older person, family care, and context of caring. Our final model will be presented in the next few slides with estimated odds ratios, and all of the statistical analysis was conducted using this data. Then first off, looking at the family care variables, significant variables associated with care burden included gender, marital status, and education. If you take gender, for example, male family carers are significantly less likely to have higher levels of care burden than female family carers, with the odds of care burden being 0.715 times the odds of increased care burden for a female family carer. Interestingly, with education, no significant relationship existed between junior and leaving cert levels, which are secondary school qualifications in Ireland. However, if family carers had qualifications beyond secondary school, there was a significant relationship with care burden. Looking at the context of caring variables, the relationship to the older person showed that adult child carers had higher odds of increased care burden than spousal carers, with no significant relationship found between other relatives or non-relative carers. So even though the odds ratio was very small, increased duration of caring in months was found to have a significant independent relationship with care burden. Intuitively, better perceived levels of support were associated with decreased odds of higher care burden. And surprisingly, care hours per week, there was no significant relationship with care burden. However, recent research has suggested that it's actually number of care tasks rather than time spent doing care tasks that's more indicative of care burden. And now finally, looking at the older person variables, there was a significant independent relationship between care burden and dementia. So the odds of increased care burden for family carers of people with dementia are 1.618 times the odds of increased care burden for a family care of a person without dementia. Higher levels of dependency are also associated with higher levels of care burden, but age and gender don't show any significant relationship with care burden. So building on the findings which support a significant independent relationship between dementia and care burden, we estimated the probabilities and marginal effects of dementia on care burden. So if you look at this column, the predicted probability column, you can see that family carers of people with dementia appear to be less likely to have low or mild care burden and more likely to have moderate or high levels of care burden. So the estimated marginal effects of dementia on care burden are all significant, and this graph illustrates what these marginal effects look like. So family carers of people with dementia are 6.95 percentage points less likely to have low care burden, 3.64 percentage points less likely to have mild care burden, but then 8.46 percentage points more likely to have moderate care burden, and 2.13 percentage points more likely to have high care burden. So caring is not a homogeneous task. Policymakers and support systems need to respond in different ways to different caring situations. The marginal effects of dementia in care burden in this study suggests that caring for a person with dementia presents unique challenges to family carers, and this needs to be reflected in the development of targeted social support systems and policies. So while the role of behavioural and psychological symptoms of dementia has been well established within the care burden literature, our study also points to the need for greater focus on other dementia-specific factors which may contribute to care burden. This includes more emphasis on social issues and psychosocial factors, including support from formal and informal avenues, education levels, particularly in relation to labour market participation, and co-residence arrangements. This study has been published online in the Journal of International Psychogeriatrics. Please feel free to drop me an email or message me on Twitter if you'd like the PDF. Finally, thanks for tuning into my presentation, and hopefully we'll be able to see each other in person sooner rather than later. So take care and mind yourselves.
Thank you very much, Anya. Lovely ending there, very, very Irish. And something that does spring to mind, it would be quite interesting to probe the reason of why carer burden might be higher for family carers of people with dementia. I don't know if you can just give us a brief, your thoughts on that.
Yeah, so I think that's a great question. Thanks, Jayne. So I think here it's really important to stay aware of the wider landscape of social issues being experienced by family carers. And while there is a very well-established literature base that is suggesting that dementia symptoms are associated with increased care burdens, which is probably one of the unique challenges that I was referring to in the presentation, it's also really important to acknowledge that there are other social issues faced by carers. So this might be things like stigma or labour market participation, even awareness and accessibility of rights and entitlements for family carers. That these are all issues that are experienced by carers more generally, including carers of people with dementia. So even though the findings of our analysis aren't specifically looking at wider social issues, there were some hints that care burden wasn't purely a consequence, of individual level issues. So yeah, what I suppose I'm trying to get at there is that although there are very real dementia-specific challenges experienced by family carers, when policy changes are being formulated, it's really important to have a mix of dementia-specific strategies and foci, as well as wider social policy changes, which would probably, both a mix of like the dementia-specific strategies and wider social policy changes for all carers would probably be the most efficient way of reducing care burden overall. So for these wider policy changes, probably the entire population of family carers would benefit from it, including carers of people with dementia, if that makes sense.
I think this highlights why it is so important that all this research is funded, the funding is carried forward so that these policy changes can be made. Now, I'm very mindful of time. We'll go to our last presentation now. Please put your questions in the chat box in case we don't get time to have them answered afterwards. Our speakers will be able to answer them in the chat box for you. Now we're going to Marianne Lingmos, and she's working as a research assistant at the Research Centre for Health and Welfare Technology, the Dementia Programme, VIA University College in Denmark. She's currently studying the everyday life and well-being among young relatives of parents with dementia. Again, we have personal experience of this. Our daughters were 14 and 16 when Chris was diagnosed. So this one I'm really interested in. Over to you, Marianne, through Nick, please.
Hi everyone, it's a big pleasure being here. In this presentation, I'm going to present to you some of the results from a qualitative study of the everyday life and well-being among young Danish relatives to a parent with dementia. The study is part of a mixed method study, and the quantitative data was presented on Alzheimer Europe in 2018. Dementia is generally known to be a family disease, as the diagnosis and the associated symptoms have a great influence on the relatives' physical and mental health, as well as their everyday life. Previous research regarding relatives has mainly focused on spouses or children below 18 years of age. There's some research on young relatives aged 18 to 30, but none has focused on the consequences that their parents' dementia has on their choices and priorities in their everyday life in the years of emerging adulthood. There's around 3,000 Danish children and young adults below 30 years of age who have at least one parent with dementia. The aim for this study was to explore how 18 to 30-year-olds experience their everyday life with a parent with dementia, and how the life situation affects the youngsters' engagement in leisure activities, social life, education, and work. With these results, we hope to contribute to improve preventative efforts and support provided by professional caregivers to this marginalized group. We conducted 11 qualitative interviews with 7 female and 4 male young relatives from all parts of Denmark. We recruited through the Danish Alzheimer Association, through social media, and through dementia coordinators, which in Denmark is a key coordinator of municipal dementia services. The participants were between 21 to 31 years old and came from very different backgrounds regarding their occupation and family situation. Most interviews were conducted face-to-face, some on video call or phone call, depending on the preferences of the young relatives. The semi-structured interviews were conducted using a themed interview guide, and data were analyzed using an inductive approach. Our results fall into 3 main categories: consequences of the parent's dementia, strategies, and choices and priorities in everyday life. In the first category, we have the consequences of the parent's dementia with the subcategories worries, shift in roles, and responsibilities and chores. The young relatives spent a lot of time worrying about the parent with dementia, and many of them were also worried about the other parent who in some cases were not doing well because of their life situation with a spouse with dementia. And in some cases, the young relatives worried about siblings as well. Some young relatives felt stressed, some felt that they couldn't concentrate, some felt that they had no energy, and a few mentioned that they felt depressed. Another consequence is shift in roles. Some of the young relatives described how their friends went home to their parents for comfort and support, but for the young relatives it was opposite. Their parent with dementia was not capable of that, and instead the young relatives had to comfort and support their parent. And they spent a lot of time with responsibilities and chores for the parent with dementia. In most cases, the parent with dementia lived alone or in a nursing home. The young relatives were doing chores like grocery shopping, cleaning, garden work, coming along to doctor's appointments, doing laundry, driving the parent with dementia around, being in charge of all contact with the welfare system, being responsible for the parent's economy, and help finding a new home. Some of the young relatives spent many hours each week with these responsibilities and chores. Some young relatives said that they were torn between feeling obligated to do these things and wishing to do them. The majority of the young relatives told that they wanted to spend time with the parent with dementia. Here, Julie gives an example on the responsibilities and chores. She said, "And then my dad got worse, which meant that my siblings and I had the main responsibility for my dad because there were no other family. So we had to take care of everything in the house. He couldn't even do grocery shopping or clean or take care of the house and the garden. So that was a lot of work for us." Strategies. Some of the young relatives were very affected by their parents' dementia and the relating circumstances. Some were mentally drained, and for some it took up a lot of their time and energy. Oppositely, a few of the young relatives told that they were okay with their current situation. The young relatives coped with their situation in different ways. One was staying occupied with work and friends in order to never be alone. One talked about it with friends and joined meetings in a relatives group. And one prioritized to run and do yoga because the physical activity took her mind off her mother with dementia. Some of the young relatives told that they found support in their partner or spouse, friends, family, and family friends. Some mentioned that it was difficult for their friends to relate to their situation. Some of the young relatives had made use of public support, such as relatives groups organized by the municipality, the dementia coordinator, and/or sessions with a psychologist. The municipal dementia coordinators that I mentioned earlier help people with dementia and their close relatives, often spouses, to receive a coordinated and appropriate support from the municipality they live in, and which should be tailored from the needs and the life situation of the person with dementia. However, several of the young relatives pointed out that since they don't live in the same municipality as their parent with dementia, the public system of the parent do not reach out to the young relatives. The young relatives will have to seek out support themselves. And most of them don't have the energy to do that, and some do not know where to seek this support. They tell about the chaotic time after the parent have been not diagnosed, where these young adults need professional support also to reach out to them. Several of the young relatives emphasize a need for more help coordinating and organizing the care for the parent with dementia. This would give them time and energy to focus on their own needs. One of the relatives lives in the same municipality as her parent with dementia, and she tells about a thriving cooperation with her father's dementia coordinator. Here, 3 young relatives tell about their experiences. Ella said, "I don't think there has been reached out. For instance, here are the offers of support, or here is someone you can contact. I had to seek out myself." Julie said, "I'm only 22 years old. What do I know? I have no knowledge about it, also in relation to legislation." And Fiona said, "The municipality that I live in doesn't know that my dad has dementia, so it's logical that the parents' municipality should reach out." Several of the young relatives feel a strong need to talk to peers. The young relatives who participate in a relatives group targeted at young relatives to a parent with dementia feel that it is helpful. But even though relatives groups are offered in all of the 98 municipalities in Denmark, only 8 municipalities have groups targeted at young relatives. The choices and priorities that the young relatives make in their everyday life seem to fit into these 4 subcategories: occupation, social life, own needs, and leisure activities. A couple of the young relatives are either postponing their education or studying part-time because they're so affected and drained that they can't focus or concentrate. Ella tells, "Right now I'm studying part-time because I've been lacking energy and my concentration has been poor because I have been so preoccupied. So I'm not quite where I want to be. I'm postponing my education by half a year because I can't manage it right now. I have also had to work shorter hours and downgrade activities that I really want to do, but that I'm unable to do due to a guilty conscience and the things that need to be done in relation to my family." Some of the young relatives mentioned that they opt out of social activities because they don't have the time or because they feel sad or prefer to spend time with the parent with dementia instead. A few young relatives tell that it's hard to be around people that they don't know or don't know well. One young relative mentioned that it's hard to attend happy events. And Fiona tells, "I'm trying to be social, but I'm starting to opt out of social activities with a lot of people or with people who I don't know because they drain me too much. So even though I love parties, I don't always have the energy." And Anna said, "Sometimes I don't go to social events if I felt the need to see my dad. Sometimes at social events, I just had to go home because I just couldn't." Some of the young relatives spend so much time and energy on chores for the parent with dementia that they don't have time and energy to focus on their own needs for getting emotional help themselves. For instance, Casper said, "I was offered 3 sessions with a psychologist in my mother's hometown, and that's fine. But if you have to take care of her economy and home, you might prioritize that over your own well-being." And Clara said, "Everything concerning the municipality and finding an apartment for my mother and sister, those things have a high priority. So your own problem seems smaller and you think, well, I'll figure that out later, or you just don't have the energy to do it at all." The preliminary interpretation of the results are illustrated in this simplified version of our model. The construction of the family situation seems to be important for the consequences that the young relatives experience. For instance, the responsibilities that the young relatives take on seem different if the parent with dementia is living alone compared to a situation where the parents are living together. Other important factors are the stage of the parent's dementia, if there are any siblings to take care of as well or to share the responsibilities with, whether the young relatives are in school or working, and if they have children or not. The strategies that the young relatives make use of, such as their way of coping with the situation and the support from family and friends and from the public or local authorities or lack of support, seem to influence the choices and the priorities that the young relatives make in their everyday life. Here are the take-home messages from this presentation. The young relatives take on a lot of responsibilities. The young relatives seemed affected to a degree where the parents' dementia influenced their everyday life, such as opting out of social activities, studying or working less hours, neglecting or postponing own needs. The young relatives emphasized the need for more help coordinating and organizing the care for the parent with dementia. Several of the young relatives mentioned a strong need to talk to peers. Thank you for your attention.
I think the main thing that I've noticed between this presentation and the presentation by Anya is the carer burden does seem to be there, but for the youngsters who don't know as much about life as the older people, they have so much more social difficulties to navigate than an older person caring for someone with dementia. We're out of time, but until we get cut off, I don't know if you want to, if you've got 30 seconds. If we start with Kirsten, can I give you 30 seconds? If there's anything you want to say?
Yeah, also thank you all other for the presentations. Yeah, maybe one quick note is also the online information program that we developed. So that's now yeah, available in the Netherlands, and we're now also in the midst of our pilot evaluation. So if people are here who want to help us out to improve their online information program even further, yeah, please go to the website.
Thank you. Tamara?
Hi, I just want to say thank you to everyone. I've answered all of the questions on the chat, so
Brilliant.
I'm quite happy. I'll pass on to others because there might be questions for Marianne.
Nina, do you have anything to add?
Thank you very much, everyone, and thank you, Jayne, for sharing and all the other presentation.
Anya, anything from you, briefly?
I think I answered all the questions in the chat there. Thanks, everyone. Really enjoyed your presentations as well. And thanks, the audience too. Thanks.
And final word to Marianne.
I'll take a look at the chat and answer the questions there.
Okay, well, thank you all for attending. Thank you for staying over time. Luckily, we don't have to go and fight for the coffee bar like we do normally. As I said in the beginning, when you've met one person with dementia, you've met one person with dementia. I think this has shown us that when you've met one carer of a person with dementia, it's exactly the same thing, because that's all we are. We are all people with dementia, without a cognitive impairment, with whatever label we give ourselves. We are all individual and unique people. Thank you so much to the researchers. I can see the potential for possibly some collaboration going on between the youngster carers and the older carers, and so maybe some research as to why is that burden there. But it does highlight the need for training for carers of people with dementia. We need to be upskilled in the role of caring, particularly for the youngsters that don't even know how to manage life. You know, in the UK, they don't know what community charges, council tax. They don't know how to access all the support that is there for anyone that we learn as we grow up. Thank you all very, very much for attending. I'm sorry it was rushed at the end. I'm so pleased they gave us the extra 5 minutes. And please enjoy the rest of the conference. Please give your feedback. Some of these slides may be available later. Some of the recordings will be available later, but you'll have to go onto the conference platform to actually find out what and where. So thank you for attending. Enjoy your coffee break, and we'll see you in whichever session next. Thank you.